Well, thank you very much. I'm John Murkin, and as you might have heard, I'm a cardiac anesthesiologist. And I've actually spent most of my career seemingly showing up at the wrong meetings. In fact, in my residency program, we had a very, very strong neurosurgical unit and a lot of interest in cerebral blood flow. And so there was a bit of surprise and possibly disappointment when I went off to do cardiac anesthesia. But I said, well, actually, I'm going to study the brain in heart surgery patients. So I think some of the observations we've made are germane to what we've been talking about this evening, and particularly the aspect that we really want to know. We don't want to make assumptions about what we're seeing in our patients. So this whole concept of being able to monitor in real time and detect the impact of the various interventions. And should make a disclosure, I'm actually on the advisory board and a consultant for Ornim because I have some particular interest in this. And just to review, of course, we know autoregulation means the ability of the brain to compensate for various changes in perfusion pressure, so that over a relatively wide range, there'll be relatively stable blood flow sufficient for metabolic demands of the brain. And of course, the first description of this concept was by Niels Lassen, really building on the work of numerous other investigators. And that's the classic curve that we're all familiar with, which is actually a composite of a number of previous studies that he'd undertaken. But the ability really to measure autoregulation is classically defined as the response or absence of a blood flow response to a step change in mean arterial pressure, classically something like phenylephrine. And of course, the gold standards, as you've heard, are the various radioisotopic investigations. And of course, the concept of cerebral autoregulation really underlies most of our management strategies, how we actually approach the patient, the types of things that we consider when we're trying to achieve various ends. This is almost of historical interest, but this is one of our patients early on, and we were using xenon cerebral blood flow to measure blood flow. We also put catheters into the jugular bulb, so we were looking at oxygen extraction across the brain, transcranial Doppler, we were doing EEG, so really multimodality studies. And the reason I'd become particularly interested in cardiac surgery is it's a tremendous model to really look at cerebral blood flow, because we can modify just about any of these variables: the mean arterial pressure, jugular venous pressure, cardiac output, temperature, CO2, hemoglobin, even anesthetics, the nature of the perfusion, pulsatile, non-pulsatile. So we did, I was quite keen in the early days, did a whole whack of studies over about 4 or 5 years and really investigated a number of these variables. Really one of the underlying themes which I think has certainly become of some renewed interest, was that given that CO2 is probably one of the primary determinants of cerebral blood flow, in a ventilated patient undergoing therapeutic hypothermia, and of course the solubility of all the blood gases increases as the blood cools, what's the appropriate ventilatory strategy? What do we do with CO2 and hence pH during hypothermia? So this was the nature of one of our first studies, and we looked at patients using that multimodality monitoring that I was showing you, and really came up with these groups of patients. So what we were looking at here was a group in which we did what was called a pH stat. As the temperature cools, we added carbon dioxide, and that was actually the standard of care. So we were measuring regional blood flows as well as global blood flow, metabolic rate in the brain. And what this really disclosed is that we had complete uncoupling of flow and metabolism. There was no relationship between metabolic rate in the brain and blood flow and pressure passive flow into the brain. And that in the other group of patients, the alpha stat, where we just allowed CO2 to fluctuate with temperature, i.e. the 37-degree CO2 was 40, here we had evidence, whoops, that's wicked, evidence for intact autoregulation. So there was no relationship between blood flow and perfusion pressure over a fairly wide range of pressures during bypass. And there was a relationship between metabolic rate and blood flow. In other words, flow metabolism coupling was better preserved, and there was evidence for intact cerebral autoregulation. Well, as you know, in the medical field, we're all somewhat conservative, and this was met with a big, amount of so what. We had no outcome studies. pH stats served us well enough. We were a little bit concerned, however, increased blood flow. If the metabolic rate is down and we've got excessive flow, is this a good thing? Well, more blood flow to the brain has to be a good thing. But we were concerned then about potential for embolic delivery and potential cerebral steal. Around about the same time, there was a lot of interest in various cerebral protectants, and Upjohn had heard one of these presentations and thought this might be a good model, again, patients that are undergoing cardiopulmonary bypass who have minor brain dysfunction afterwards, that potentially we could look at various cerebral protectants. So we ran a series of conferences, came up with consensus statements, how to assess not only stroke, but more subtle brain injury using cognitive testing. And a number of years later, we were able to get the funding to finally do a more definitive outcome study. And what we're able to show is it really did make a difference, that how we manage carbon dioxide levels during bypass, this is a randomized blinded study, pre and post-operative cognitive testing, that 2 months after bypass, we could tell which patients had received a higher CO2 level for 90 minutes on bypass. A 12 millimeter change in CO2 during cardiopulmonary bypass made a significant difference to the integrity of their intellectual processes, cognitive performance after bypass. So that certainly impressed me. A very small change could have a profound difference. And of course, as you're aware, this whole concept of autoregulation now is really being revisited. It's apparent, or it's clear that this autoregulatory threshold, this curve that we have, is really a construct. And it was really a paradigm that included a variety of patients receiving various pharmacological agents, preeclampsia. There was a whole range of conditions that were all sort of put into the mix to come up with what's a very nice, smooth-looking curve. So conceptually, it's beginning to be questioned. And that introduces this concept now of dynamic cerebral autoregulation. You've heard a little bit about this. And certainly Rune Ostlid, and I see Arthur Lamb here. Arthur is one of the first people I heard talking about this concept. And this is really looking at the instantaneous changes that occur with changes in blood pressure. How does the cerebral blood flow respond to these kinds of changes in perfusion? And as you've just heard, the preservation or loss of this dynamic component of autoregulation is an indicator of the integrity of the cerebral vascular reactivity and potentially fluctuates during the course of a patient's illness. And so maybe an important marker. This paper was published relatively recently in one of the neurocritical care journals. And I found it quite interesting and quite relevant to the issue we're talking about here now. This was 8 patients with a large ischemic stroke. So they induced mild hypothermia down about 33 degrees, measured all of the routine ICP, mean arterial pressure, perfusion pressures, maintained a CPP over 70, and they baseline ventilated these patients with alpha-stat. So at 37 degrees, kept the CO2 at 40. And then they measured cerebral blood flow sequentially using the old technology, using xenon, exactly as we had done. And after 30 minutes, they would maintain them on alpha-stat, and then for 30 minutes they'd switch them over, either continue alpha-stat or switch them to pH-stat. And this meant a 7 to 8 millimeter change in CO2. Did this on 3 days sequentially. And what they found was that on day 3, that the patients, 2 of the 8 patients in whom they allowed the CO2 to go up by 8 millimeters, evidenced brainstem herniation, blew a pupil, and had to be resuscitated. So these are the CO2 values. So the kind of thing that one sees in many ICUs and certainly the operating room on a routine basis, relatively small change in CO2. So these very subtle changes in susceptible patients may incite profound consequences. And I walked through some of the posters today. and I was intrigued by the apnea test. And as you know, doing an apnea test, providing oxygen, as CO2 goes up about 3 to 5 millimeters a minute. So, over about 10 minutes, you'll have about a 5 to 10 millimeter increase in CO2. So the kind of CO2 changes we're talking about that in this particular setting induced brainstem herniation. And the point is just to say that if we're not monitoring these things, if we're not critically aware, suctioning, endotracheal suctioning, all of these events that go on a routine basis in any ICU in a susceptible patient may well have very profound consequences. So who's susceptible? This is some of the more recent work now looking at dynamic autoregulation. This is from the group at Hopkins. Again, they were using patients during cardiopulmonary bypass. And they were using whoops, sorry, that is really wicked, it's biting me. They were using near-infrared spectroscopy and transcranial Doppler to assess the integrity of dynamic autoregulation. And what they found was that there was a correlation that those patients that had impaired autoregulation during bypass had a significantly higher associated risk of stroke. So indicating once again that this impairment of autoregulation may lead to very detrimental consequences in a variety of settings. So this is just some of our current data. We're currently doing some studies now with the Ornim device, and that's what we see on the bottom here. This is measuring both the cerebral flow indexes as well as brain saturations. We're also doing transcranial Doppler, so we're looking at the correlations between changes in MCA flow velocities and changes in CFI in various settings, including cardiac surgery. Some of these patients have selective cerebral perfusion for arch procedures, and we're starting to look at some other cases as well. This is just a representative demonstration from one of the patients, and this is just looking at their transcranial Doppler and CFI responses. And I think this is a patient where the autoregulation was significantly impaired, but showing that the two measures seem to travel in parallel. One of the things I find quite interesting, and this is early days for us looking at this technology, but because it's NIRS-based, we're actually looking at the microcirculation. So we're getting a flow index that allows us to look at the microcirculation, the microcirculatory flow dynamics, as well as the oxygen saturation in those tissues at the same time. And we found something a little bit intriguing. Certainly in open chamber cardiac procedures, we often see showers of gaseous microemboli. It was quite curious. We just saw there seemed to be these transient instances where bulk flow through the MCA versus flow through the microcirculation as detected by the NIRS seems to be directionally opposite. So this is something we're very intrigued at and we're starting to look at more closely. But it suggests again that here we're able to actually look in real time at what's going on really at the engine of the brain, of the actual metabolic processes in real time. So I think it's quite intriguing. We have a lot of potential. Right now we have the potential then for looking at a real-time monitoring of cerebral flow. The potential for cerebral oximetry, is very much there, as well as the opportunity for a real-time assessment of dynamic cerebral autoregulation and this concept of real-time flow metabolism coupling, which I think will provide potentially a lot of insight into how we manage our patients and how various interventions that we're doing, whether they're moving things in the right direction or not. So I'd like to thank you all for your attention, and hopefully we can have time for some questions and good discussion. Thank you.